So I'm going to talk about this new technique, and what brings us here, Giuseppe Milano, is the Hippocratic Oath telling us primum non nocere. So what if we found a solution for subcritical anterior glenoid bone loss that could give us the same effect as a Latarjet, so the hammock and the sling effect, and we could do this without using bone or hardware, because as we heard from Ruth Delaney's excellent talk, there are severe risks of lesions using the Latarjet technique. So what if we could have a technique where we could avoid bone on cartilage lesions, where we could avoid hardware on cartilage lesions, where we could avoid neurological lesions to the axillary nerve or the musculocutaneous nerve, which in this patient sometimes is already damaged from the dislocation, as we heard in previous talks. What if we could avoid vascular lesions? So this is what is behind the development of the dynamic anterior stabilization. We transfer the long head of the biceps to the anterior glenoid through a subscapularis tendon split to try to mimic the Latarjet effect without using the conjoined tendon and the bone. And this brilliant idea was developed by many surgeons around the world, but the ones that pioneered this were Philippe Collin and Alexander Laderman in their publication in Arthroscopy Journal, where they showed a technique where they transferred the long head of the biceps to the 3 o'clock position on the anterior glenoid, augmenting a Bankart repair. However, they used an interference screw, and this could risk glenoid fractures. So did this technique developed in China, where they transferred long head of biceps through a tunnel and they fix it posteriorly using a mini plate at the 4 to 5 o'clock position. In Brazil, our friend and colleague José Carlos Garcia developed another technique where the idea was to put the long head of the biceps, instead of an inlay position medial to the articular cartilage, more lateral, so in an onlay fixation type. And in Russia, Oleg Milina developed this technique based on an open technique, the Weinstein procedure, where the main idea is not only to transfer the long head of biceps to use it as a hammock and a sling effect, but also this onlay technique where they do a labroplasty. And this effect for us was the most significant, and this was the idea we wanted to reproduce, because most of these patients, particularly the patients who dislocate frequently because they have an insufficiency in the anterior labrum and the capsule, we wanted to reproduce the effect, the bumper effect, and the concavity compression that stabilizes the glenohumeral joint. So this is why we modified this technique to try to make it simpler, all arthroscopic, without the need to transfer the biceps and have the step that's ex vivo suturing the biceps. We do this all arthroscopically, and we published our first 3 cases in JBJS Case Connector journal, showing that using this onlay technique, this minimal labroplasty effect, using 2 all suture anchors, allowed the long head of biceps to heal to the anterior glenoid. In 2022, Ion, who is here and is going to talk later, added the heel sacs remplissage to the dynamic anterior stabilization, and also in India, our colleague Nair also proposed using the heel sacs remplissage as an added effect to this technique, and José Carlos Garcia published yet another technique for this. So this is very popular worldwide nowadays because we want to help our patients without having neurovascular complications, which is a high risk when you do a Latarjet. So in our technique, we do this in a beach chair position, all arthroscopic, with only 3 portals, the posterior, the anterior, and the anterolateral portal. And we're going to use an anterior cannula, but before you do that, one of the main steps of this technique is to clean the rotator interval, because you're going to do this all arthroscopic. You're going to transfer the long head of the biceps to the anterior glenoid through the subscapularis tendon split. So you cannot have any soft tissues interposed, so you have to remove all this, and you use the anterolateral portal placed from outside in as a working portal, where you use the radio frequency ablator to continue this. So you mark the placement of 2 all suture anchors at the 5 o'clock and the 4 o'clock position, because you're going to have a laying effect to produce this mini labroplasty effect of long head of biceps in the anterior glenoid. And you're going to decide the split based on the position of the anchors as well. But in this technique, this is not as relevant as in the lat Target. So you can place the subscapularis tendon split from between the upper third of the subscapularis tendon to the middle of the subscapularis tendon. And after you do this, you perform the split using the radio frequency ablator, and you're very safe because you're always lateral to the conjoined tendon. And you're going to see while we do the split that then we can see the axillary nerve is medial, the conjoined tendon is medial, and one of the main advantages of this is that actually, because you're transferring the long-headed biceps and not the conjoined tendon, you're not placing traction on the musculocutaneous nerve, or on the axillary nerve for that matter anyway, after placing the graft, which is in this case the long-headed biceps. So use an all-suture anchor double loaded with sutures, because the main aspect of this technique is we're using a double pulley effect to transfer the long-headed biceps. So you arm the all-suture anchor, you pull on the sutures, and then you're going to pass all 4 suture limbs distally on the long-headed biceps, so proximally to the transverse humeral ligament, but the most distal as possible. And then you park the sutures in your anterolateral portal, because also suture management here is key. So you do this 4 times with this anchor, and I'm going to fast forward this for time's sake. And then you're going to do the same after you place 4 o'clock anchor, which is what you're seeing here now. So approximately 1 centimeter proximally to the 5 o'clock anchor, you place another double-loaded all-suture anchor. You pass this all 4 suture limbs through the long head of the biceps, and you end up with 8 suture limbs on the long head of the biceps, and this is all done all arthroscopically. You no need to pull the biceps ex vivo to do this. Then you're going to have to tie 2 knots, which are going to be the double pulley. And then you're going to pull on the opposing limbs of sutures, which is going to cause the double pulley to push the graft inside. So this is what I'm fast forwarding for you. Oh, here you have them. The first double pulley knot, and then the second double pulley knot. So then, after you cut the suture limbs from the double pulley knot, you're ready to cut the transverse humeral ligament. This is a key step in this procedure, because you're going to need the long-headed biceps to dislocate medially. So you're in the beach chair position, the shoulder is forward flexed, you can see the transverse humeral ligament until the long-headed biceps dislocates by the pulling force of the sutures that you've already passed, and then you complete the tenotomy on the biceps anchor on the superior labrum, and then the long-headed biceps is free to go towards its goal, which is the anterior glenoid. And this is why you need to clean the rotator interval very carefully, otherwise this is not going to go smoothly. And after you do this, you can tie the other 2 knots from each of the anchors. You end up with 4 knots fixing the long-headed biceps to the anterior glenoid. So 2 anchors and 4 knots fixing, and we've shown in our series that this heals. So I'm going to fast forward again to show you what it looks like in the end. Here we go. Looking from the anterolateral portal, you see the long-headed biceps in front of the humeral head, and this avoids the dislocation anteriorly, but also works as a hammock because it pushes the subscapularis tendon down. So one key factor from rehabilitation is that these patients are allowed to externally rotate immediately after surgery and forward flex the shoulder, but another thing that you have to be careful about to have these results is that you cannot allow strengthening of the biceps until 6 weeks. The rest is identical to other procedures, but we don't allow contact sports until 6 months. So it's all about the data. Philippe Collin and Alexander Latterman published theirs, and they show that in 22 patients with less than 20% of anterior glenoid bone loss, they had only 3 recurrences in the early learning curve because they placed the long-headed biceps too medial. Alex now is putting the long-headed biceps more lateral to avoid this. And they reported no long-headed biceps complications. In our series, with a mean follow-up of 2 years, we also had one recurrence. It was in another animal, severely hyperlax patients, where we did not address sufficiently the inferior glenohumeral ligament to tension it. So our series is actually very, very good results. We found that patients that had off-track lesions intraoperatively became on track. So our average patient had 8.2% of anterior glenoid bone loss, and 1/3 of the patients had slap tears, which is a very good indication for the procedure. They improved significantly in all scores. The return to play rate was 93%. And even the patient who dislocated after this procedure, dislocated under the biceps, as I told you, severely hyperlax patient, and the biceps continued to be in the same spot that we placed it, completely healed there. So as I was saying, we report no complications in the biceps. You see here patients going as forward as 4 years after surgery. As you see, this patient, 4 years after surgery, now is actually at 5 years, no differences in symmetry of their biceps. I'm going to play these videos because they're not running automatically. I don't know why, but I'll give them some help. Okay. And another case series, very good one, with 33 patients doing the DAS. They had no recurrences at the minimum follow-up of 3 years. And this is the technique that I told you about from China, using the mini plate posteriorly to fix using ethanol the long head of the biceps. So in conclusion, this is a technique that provides, and this has been shown biomechanically in studies like Lubon's study, a dynamic effect through the pushing of the subscapularis tendon down and the sling effect, avoiding the anterior dislocation in higher degrees of abduction. You don't lose any external rotation, and this has been shown in biomechanical studies and in our series, particularly because we stimulate patients to initiate external rotation immediately post-operatively. Biomechanical studies have shown that this decreases the anterior glenohumeral translation in anterior glenoid bone defects ranging from 10 to 20%, so this is a very good technique for subcritical glenoid bone loss. It deals with the slap lesion, so you fill 2 needs with 1 deed. The patient having a slap tear, you're doing a tenodesis to the anterior glenoid in the patient that you treat with the tenodesis. And you avoid hardware or neurovascular complications because of all the reasons I told you, and in our technique in particularly because we only use all suture anchors, and this is, like Angelo explained, very good for post-operative follow-up. And we use no specific instrumentation, 3 portals, but the main disadvantage is the patient that comes asking for the 3 months surgery, like Ruth said, so this is not a surgery for them. We need to delay return to play. So this is safe, it's good for subcritical glenoid bone loss, usable in slap lesions, but be careful with severely hyperlax patients. We are now adding a hillside remplissage in these patients as well as application. So you're invited to our course in 28th of September. Thank you.